So thank you. Actually, I'm going to be arguing against treatment, not against testing, but in some ways testing too. So I'll be arguing against myself, I guess. But anyway, so we're going to be talking about novel targets such as HER2. I also will be talking about BRAF as another target, and make the case that these are not ready for primetime colorectal cancer. And I think I agree with Howard that the best options are clinical trials right now for those two modalities. So we all, well, most of you who may be old enough to remember, this was in 2001 with imatinib in CML and then GIST, and the thought that this is now what we're going to be doing to cancer, that we have new ammunition, we have bullets, these magic bullets, and we're going to hit every cancer without affecting normal tissue. Well, it turns out that that's mostly not true, and for the years to come after this was published, we haven't really developed a lot of these, what we call smart or magic bullets. So we still think we know the right fit and hope to hit the target. We think we do know for most of our agents what is the perfect match. But it turns out that actually mostly it's not true, and we have multiple examples of that. There are very few agents who actually fit the bill, and these are unlikely to be readily available. They're mostly, when we're thinking about our clinical applications, they're experimental. There are clinical trials out there that are restrictive. Cost, toxicity, and of course, we don't know whether we can apply single agents, combos, but then the toxicities are worse, or apply what we call the dirtier drugs. And then when we think about certain mutations or alterations in some cancers, they may work in one cancer like magic, and another cancer they show no activity. So we're left with this. Anytime we pull one of those reports, one of those NGS reports, they're going lots of different directions. Most of the time, we don't know what the heck we're doing with these reports. So think about in melanoma, V600E and vemurafenib, great response, 76% in refractory colorectal, 5%. So when we think about these oncogene mutations, this doesn't necessarily imply oncogene dependence. So if a mutation seems to be driving one cancer, this presence of a mutation in different cancer is not necessarily a driver. And there are other reasons, because we may have other proteins or methylating factors that may be actually differentially expressed in different cancers. So what we know is just the tip of the iceberg. Most of the iceberg is still hidden. Well, there's a lot of discovery happening, and to work that's been done by a lot of groups, including Dr. Hochster's group. They were understanding a little bit more about what's going on with gene selection, signatures, etc., that will help guide us a little bit better in terms of finding the right fit. So, from the clinical perspective, you see a lot of clinicians, including myself, we test for these, we send for these expensive NGS testing, Foundation Medicine, Caris, and others. But the argument had always been, do we really need to interrogate the whole genome, or whatever number of genes are included or alterations are included in those different tests? Or should we just be more focused on what's applicable to the clinic? There are pluses and minuses, of course, about doing one or the other. If there is availability of clinical trials, there's no argument. The more you actually throw that fish net, the more likely you're going to find targets that could be applicable to your trials, to put patients on trials. But other than that, you're mostly exposing patients to costs that may be unnecessary. So this is the financial toxicity component. And then there's another element, and we'll try to talk about this at the end a little bit, is, let's take your colorectal cancer patients who had a surgical resection 2 to 3 years prior, or a couple of years, let's say, prior, comes to your clinic with new metastatic disease, and you just take that tissue from 2 years prior. Is it still reflective of what's going on today? Certain things may change, a lot of things may not. So the timing of the test certainly can affect how well we actually direct patients to the right therapy. I don't know if you can see this too well, but this was a very interesting summary of studies that looked at personalized cancer medicine. And essentially, in this, the Shiva trial, which was recently published. Now, you can argue that with the Shiva trial, there were a number of issues in terms of the agents that were selected. But this was the first prospective randomized trial that essentially looked at assigning patients to a target therapy based on the alteration versus standard of care. And no difference was found between the two arms, meaning that personalizing medicine or applying precise medicine didn't necessarily improve outcome versus no standard of care. Then I'll turn you to those two studies here from MD Anderson and Princess Margaret. And essentially, it takes, in both studies, there were a couple of thousand plus patients, plus in one, a little bit minus in the other. Out of those, about 80 plus % of the patients had a genomic profile that you could essentially interpret. About half of the patients overall had what you consider an actionable mutation, to which about 20 to 30% of the patients actually had an agent that you can recommend to this actionable mutation. Ended up with about 4%. Now, this number keeps on going down. 4% of the patients who actually ended up going on an actual target therapy. And in the Princess Margaret study, 20% of the patients who went on that fantastically precise agent ended up with a response versus 11% on standard therapy. So what does that tell us? I mean, how much resources are we spending essentially to benefit, and we don't know what the extent of that benefit, the very few patients, if any. This actually comes from from the group, from my previous group, which essentially was presented at ASCO, and we looked at all our patients that undergone NGS, essentially. We found that 15% of them ended up with potential genotype-directed therapeutic options, and only 5% ended up actually going on some form of therapy, and actually most of these patients did not benefit from their therapy, and this is the listing of the reasons why they didn't benefit. So now moving on to talking about some of the more relevant targets, and we think about EGFR therapies as the way we personalize therapy in colorectal cancer right now. Right, we're adding a couple more targets, but we don't know how to select for patients who respond for EGFR therapies. We know how to select for the patients who do not respond and should not be exposed to these EGFR therapies. And these could include patients with HER2 amplifications as well as BRAF mutations and then the RAS mutations. So to focus really on the two that we consider are a little bit more relevant targets right now, it's HER2 amplification and BRAF V600E mutations. So HER2 is present in about 3.5%, 4% of the patients. V600E BRAF mutations, about 10% of those who have wild-type RAS, so which ends up being about 4 to 5% of all your patients. And both are negative prognostic elements when they're present. There are less common targets. You've heard about MSI in 4% of the patients, and are not even, others are not even close to prime time. They're less than 1%. And then the predominant mutation is RAS, and RAS, as we know, is not druggable, at least for now. I mean, there are ways to try to get close to drugging its downstream signal, but it doesn't seem to have much of an effect in colorectal cancer. So I'm not going to belabor over the study. Dr. Hochster presented that beautifully. But essentially, it's a study that looked at HER2-amplified colorectal cancer patients. One cohort received trastuzumab lapatinib, the other one trastuzumab pertuzumab, and we have the results of the lapatinib plus trastuzumab, which looked very interesting. With caveats, of course, there's another study called My Pathway that also had looked at HER2-positive tumors, included colorectal cancer cohorts. All these are very small numbers, very highly selected patient populations. And so at this point of time, yes, it looks very interesting, but we have limited data frankly, on the dual therapy. We also don't know if we should combine trastuzumab with a TKI, or is it better to combine it with another antibody, such as pertuzumab, and what's the role of chemotherapy. And frankly, also understand the role of other HER2 alterations, such as mutations, and whether they apply elsewhere. So frankly, more research studies are to be done. So for the clinic today, I don't think they're prime time. I think you really need to consider a clinical trial when you found those amplified or overexpressed. Larger number of patients. We also need to understand a little bit more. Do the 3+ do better than the 2+? Does it matter in terms of our selection? And also understand the mechanisms of resistance. A number of studies are actually looking at that space. This is going through our accrue network with TKI, a novel TKI, ONT-380 plus trastuzumab in patients with HER2 amplified metastatic colorectal cancer. And Dr. Hochster talked about the SWOG study that's ongoing, which is a randomized study looking at the combination of the 2 monoclonal antibody plus chemo versus cetuximab plus irinotecan. Now moving on to another target, that's also found in colorectal cancer at a level of 5%, and if you take just the RAS wild type, about 8 to 10%. So as we said, the first studies that looked essentially at mostly single targeting, and some actually doubled up on the target, you can see that the response rates have been really dismal, about 5 to 10%. So nothing like melanoma, where the response rates have been north of 60, 70%. And then when combined with EGFR, so understanding that part of the mechanism that could essentially lead to escaping that pressure on BRAF is essentially through the loop that leads to EGFR is combining these agents with EGFR inhibitors. The response rate have actually doubled, and the progression-free survival started to inch up. And then when you actually start looking at triplet therapy with EGFR plus BRAF inhibitors plus chemotherapy or plus MEK inhibitors, then your response rate triples versus single agent, and you start seeing PFS closer to 4 to 5 months. And this study was recently presented by my friend Scott Kopitz, essentially, SWOG 1S1406, that looked at antican and cetuximab with and without vemurafenib in BRAF mutated colorectal cancer, and did show that there is definitely a signal in the study for adding a BRAF inhibitor to antican plus cetuximab. Notice that cetuximab seems to have almost no activity or minimal activity at best in this group of patients with BRAF mutated tumors. There were responders, more on the BRAF inhibitor arm, but as you can see, very few of those are still ongoing. So I think it's too premature to say that this is the best way for us to treat those patients, but this certainly is interesting enough to move forward to larger studies. And one of those studies is the Beacon study, led by both Kopitz and Tabernero, and looking at encorafenib, which is a BRAF inhibitor, plus cetuximab, plus minus a MEK inhibitor. So this is the study that hopefully will tell us whether there is validity to targeting MEK and EGFR plus BRAF in patients with BRAF mutated tumors. It's a large study going internationally. So, as a conclusion, I think, the takeaway point from this is novel targets such as HER2 and BRAF, yes, they are interesting, but they are not ready for prime time in colorectal cancer. And by prime time, I'm talking about actual use in clinic. They're prime time for research. It's important to actually support ongoing studies, which will help us elucidate the role of these and other targets. So in terms of one of the key remaining challenges, I think, for us is, I'll go back to the first point, is the timing of that biopsy. When we actually acquired the first tissue from those patients, these colorectal cancer patients, sometimes they go 2-3 years. Even with metastatic disease, the disease goes through multiple changes through the pressures of a lot of these target agents we may use along the way. And so I think that liquid biopsy may offer a solution as a comprehensive view of the systemic disease, changing clones, spatial molecular heterogeneity, et cetera, and maybe the way eventually how we're going to be looking at real time, not just at what's changing in the tumor, but also get a good snapshot about the overall cancer load or tumor burden in the patient, in the patients as they get treatment. And as such, we actually have a study that's going to be launching soon through our accrue network, looking at a study called Colomate. It's looking at serial liquid biopsies, essentially in assigning patients based on circulating free DNA findings. And these are some of the proposed baskets that we're including in this study, and many of them are starting to fill up, and this will be ongoing. So we'll understand also in the study how some of the changes are happening as the patients go through the various target agents. So I'll finish at that, and thank you.